Mycobacterium. So with acid-fast bacillus, or AFBs, some of these species are pathogenic, others are opportunistic, and others are considered normal flora. These bacteria can cause tuberculosis, leprosy, and non-tuberculosis pulmonary disease. They are typically slightly curved to a straight bacillus. They may be branching. They may demonstrate filaments. They are non-motile and non-spore forming. So why do we call these acid-fast bacillus? It's because the cell walls of these organisms contain high levels of mycolic acid or fatty acid, which makes the genus acid-fast. So we will use an acid-fast stain, and we will not use a gram stain to try to visualize these organisms. Processing and working up initially, as well as working through identification safety, is of utmost importance for working with Mycobacterium tuberculosis, or really just any acid-fast bacteria. So Mycobacterium tuberculosis is actually transmitted primarily through inhalation of airborne droplet nuclei. So everything that we do, we have to go the extra precaution to prevent any type of aerosols, because those aerosols can be infective. Your personnel training will include having your annual PPD test, your TB skin test, and if that's ever positive, then you'll do a chest x-ray from then on to hope that it does not progress. We will wear additional protective gowns, masks, gloves, and use a biosafety cabinet. Before and after use, we will use an appropriate germicide, which is usually an amphil, based not on our usual bleach. Then you'll finish, well, when you're done with your workspace, you'll turn on an ultraviolet light because that UV light can help to kill this bacteria as well. Specimen processing and sterile specimens. So sterile tissue or some type of sterile body fluid does not need a digestion decontamination procedure done. Tissue will be ground in saline or bovine albumin and then plated. If we have a large amount of body fluid, maybe this is like from a thoracentesis or a pleural fluid, you will concentrate that. So you're going to actually spin it in the centrifuge and then plate to both a liquid and solid media. When we talk about tuberculosis or Mycobacterium tuberculosis causing tuberculosis, you can think of the pulmonary system. Most of the time what you're going to get is a sputum specimen. So whether it's an expectorated or aspirated sputum, we will have a lot of normal flora that is going to contaminate that organism or specimen. So we're going to have to use the digestion decontamination procedure, which will help to liquefy the debris and it'll help kill any contaminating organisms in the specimen. So you have two different agents to break up the mucus of the sputum. So you have an N-acetyl L-cysteine reagent, which is a mucolytic agent against breaking up the mucus strands in the sputum. And then you have a sodium hydroxide, which is used to decontaminate the specimen, so that kills off the normal flora, but it does not kill off the acid-fast bacteria. And then sodium citrate can be used to stabilize the acetylcysteine if needed. So if you're processing a sputum, a gastric lavage, a tissue, urine, or other body fluids, you may need to do that specimen prep, either the digestion or decontamination procedure. So for the digestion decontamination procedure, for reference, make sure you see the full procedure in your textbook or the video below also. So this is used for sputum, gastric lavages, urine, tissue, and other non-sterile body fluids. Its purpose is to liquefy mucus and debris, decontaminate the specimen, so basically eliminate that normal flora without harming the mycobacteria. So for general steps, we're going to mix the specimen with the NaLC sodium hydroxide citrate solution. We're going to allow to react for the specific time, which is typically 15 to 20 minutes. Then we're going to neutralize with buffer or sterile water, and then centrifuge at 3,600 rotations per minute for about 15 minutes. We're going to discard that supernatant that was used. We're going to use the sediment, and that's going to be used for acid-fast staining, for culture, and molecular testing. So we can separate acid-fast bacillus based on their growth rate as well as their pigment production. So slow growers are typically anything that takes more than 7 days to see any type of growth. Examples of your slow growers are Mycobacterium bovis, Mycobacterium kensei, and Mycobacterium tuberculosis. For rapid growers, we will actually see visible colonies in less than 7 days. So your rapid growers would be Mycobacterium fortuitum and Mycobacterium coloniae. And then we have what is referred to as the Runyon classification. So the auger is set up in duplicate or one that is shielded from the light, and the other one will actually be in the light. So we're looking for a yellow pigment, so it'll be like a yellow to orangey color. So you have a photochromogen is going to be classified as an organism where we only get pigment when it is exposed to the light. A chromogen is a pigment in the light or in the dark, and a non-photochromogen is there's no pigment production whether it's in the light or not. So keep in mind your growth, and then keep in mind your Runyon classifications, and then that is actually how, a nice way to determine between the different Mycobacterium species. So Mycobacterium tuberculosis, sometimes this is referred to as Mycobacterium tuberculosis complex, which includes Mycobacterium tuberculosis, Mycobacterium bovis, and Mycobacterium africanum. So Robert Koch was the one that determined that Mycobacterium tuberculosis actually causes tuberculosis. This is a slender and a slight or straight curved organism. Generally, they are found in singles or occasional threads. Even when it does grow, the auger will be more of a granular or beaded type appearance, so it is not smooth. Domed colonies, like most regular organisms, and it can take up to 3 to 6 weeks for it to grow. Colonies can appear dry, rough, raised, thick, and oftentimes with like a wrinkled type surface. It will be buff in color, so it is non-pigmented. So tuberculosis specimens contain large amounts of normal flora. Your most common specimen is going to be sputum. So therefore, you must do the decontaminant and digestion procedure before it's inoculated to the auger. Tuberculosis causes tuberculosis, chronic infection. The route of entry is inhalation of the airborne droplet nuclei. So again, much higher levels of precaution for not creating an aerosol as you work are needed. Exposure is determined by chest x-ray, and lots of times they'll use a positive skin test as well. A chronic state may progress to an expectorated bloody sputum. So if they've had it for a while, the sputum that you get may actually be bloody. Extrapulmonary infections that are actually caused by Mycobacterium tuberculosis can occur. So these can be found in the genitourinary tract, lymph nodes, bone, and brain. For specimen collection, they need to be transported and processed as soon as possible. Most of the time when we're ruling out tuberculosis, sputum will be the most common specimen type, and then they'll use multiple. So they may do it, 3 times daily. So for example, like I said, you may get it 3 times daily, or you may get it as a gastric washing as well. Other specimens can include urine. Typically, it's going to be the first morning clean catch. It could also be a cerebral spinal fluid. It could be a biopsy. Again, anything with a lot of mucus, anything with a lot of normal flora is going to have the decontamination digestion procedure performed. So again, most specimens are going to have normal flora. So we just need to kill those off, and then your more hardy acid-fast bacillus will remain. So your sodium hydroxide is what is going to decontaminate those specimens. NALC is a mycolytic agent which helps to digest the sputum. You can use drug therapy. So most mycobacterium are also multi-drug treatments. So you have to use more than one type of drug to actually treat these. So your choices for that are isoniazid, ethambutol, rifampin, streptomycin, and pyrazimide. So typically with a combination of the two that's used to treat the patient, we typically will not do antimicrobial susceptibility testing to start, but we will potentially do some susceptibility testing on patients when their sputum remains acid-fast after they've been on the treatment for 6 months, or if a patient were to revert from negative to positive. Mycobacterium leprae causes leprosy. This is also called Hansen's disease. So leprae is a slender, long, club-shaped cell found in groups of the cell-like bundles of a cigar. Leprosy is a disease of the skin mucous membranes, and it can also be found in the nervous system. We are typically not able to culture these guys, so it's going to be diagnosed on presentation of the patient. Treatment is going to be with Dapsone, and that's going to be your drug of choice. So here's a photo of a chromogen called Mycobacterium-Microbiology. It does cause pulmonary disease. It is a long branched beaded cell on an acid-fast bacillus smear. The colonies are smooth but will develop to a rough texture, buff in the dark, and it'll turn a lemon yellow after it has been exposed to the light. So again, that is your definition of a photochromogen. When it's exposed to the light, it produces that pigment. It is sensitive to isoniazid and streptomycin, and this may be a triple therapy needed, so you may need to also be treated with rifampin. Mycobacterium gordonii is found in the water from faucets, found in the environment, and it's also found in the soil. This is a scotochromogen, so it pigments in both the light and the dark. It is rarely associated with human disease, and it does fall into the slow grower category. Mycobacterium scrofulaceum is a slow grower as well. It is smooth, domed to spreading yellow colonies in light and the dark. So again, it's a scotochromogen. It causes adenitis, bone, and other infections, especially in children. Mycobacterium marinum, this is a photochromogen, so only pigment is going to happen when it's exposed to the light. It is found in water. It is associated with granulomatous lesions of the skin, especially in the extremities. So think of swimming in the lake, you scrape your foot on a rock that's underwater, that type of thing. So your infection is usually after an abrased skin is exposed to that contaminated water. However, risk can be seen in home aquariums, bay water, and swimming pool. Mycobacterium marinum is susceptible to amikacin and kanamycin. Mycobacterium avium intracellular complex is difficult to separate avium from intracellular, so that's why they put it together as a complex. It's a non-photochromogen, so there is no pigment in the light or the dark. It is a slow grower, so again, it takes more than 7 days to grow. Colonies are domed and opaque looking. This is considered an opportunistic pathogen that is seen in AIDS patients because of their immunodeficiency status. It also causes cervical lymphadenitis, so your lymph nodes under the armpit, that's considered your cervical region, so those types of things will be swollen. It can cause tuberculosis-like endobrachial lesions, and the complex is resistant to a lot of anti-tuberculosis agents. So staining, again, this is not a gram stain. This is going to be a Zeal-Nielsen or Kenyan method. It could be a fluorochromatic stain with aramine and rhodamine. 50 to 80% of tuberculosis patients will have a positive sputum smear. So you have a procedure for the Kenyan cold stain in your textbook, so I would take a look at that. And you will read a lot of fields for tuberculosis. So generally you will observe 300 fields before you can report it out as negative. A different set of media is used for these organisms as well. So we have a Lowenstein-Jensen agar. This is an egg-based media which includes a malachite green. The malachite green inhibits contaminating bacteria. So this is going to look like a light blue-green color. We use quite a bit of tubed media versus plated media for tuberculosis selective agars. For acid fast, we would use Middlebrook 7H10 and Middlebrook 7H11. We also have two sets of initial agar because we're going to incubate one in the dark and one in the light, and that is once again so we can determine the Runyon class, if it does color or not. Your other testing could include niacin, nitrates, catalase, tellurite, tween 80, and TCH. We'll also use growth rate and pigment production to separate, as mentioned before. So use of growth rate and pigment production to separate works fine, but because they can be a slow grower, sometimes we need results faster than at least a week or longer to determine if they are present or not. So we can actually use PCR. We can use nucleic acid probes, radiometric methods, and sometimes there's a Bactec 460 that we can also use. So that's kind of like your blood culture system that would actually be able to detect an acid-fast bacillus. Again, we don't routinely do antimicrobial susceptibility testing with your acid-fast. However, if it is a life-threatening disease and we've had failed therapy or recurrent therapy or multi-drug resistant tuberculosis, your suggested drug regimen is to start with isoniazid, rifampin, and pyrazimide. If the regimen doesn't work, then you may need to add ethambutol or streptomycin. Susceptibility testing will happen if the patient has a relapse. So if they reverted back to a positive after being negative, or a smear is positive after 3 to 6 months of treatment.